Good evening. This is Novel Therapies for Chronic Rhinosinusitis with Nasal Polyps, supported by an independent grant from GlaxoSmithKline. My name is Dr. John Basso, and I'm joined tonight by Dr. Michael Wexler. I'm professor of rhinology. I'm an allergist immunologist in the ENT department at the Perelman School of Medicine, University of Pennsylvania in Philadelphia. Dr. Wexler is also a professor of medicine. He's director of the Cohen Family Asthma Institute, the Division of Pulmonary Critical Care and Sleep Medicine at National Jewish Health in Denver, Colorado. Here is our accreditation credits and accreditation statements. In order to obtain your CME certificate, you'll need to complete the evaluation by September 24th. University of Cincinnati has regulatory slides here for conflicts of interest. And here are our disclosures, my disclosures, as well as Dr. Wexler's disclosures. Here's a disclosure of unlabeled use. We may discuss non-FDA approved therapies, and these will be noted as such. Our learning objectives this evening are to outline the pathophysiology of rhinosinusitis associated nasal polyps and guiding the selection of novel therapy, biologic therapy. Number two, to accurately diagnose patients with CRS with nasal polyps who may be eligible for treatment with biological therapy, and to discuss and evaluate emerging agents for CRS with nasal polyps based on their efficacy and safety data. Here is a pre-test question. Which cell is most important to the development of type 2 CRS with nasal polyps? Eosinophils, innate type 2 lymphocytes, Th2 cell, mast cell, or E, no one cell is completely responsible, rather it's a coordination of multiple inflammatory cell types that produces type 2 nasal polyps. Okay, so I'm going to start tonight by discussing the overview of the pathophysiology and guiding therapy. And Dr. Wexler is going to talk about biological therapy in more detail. First, we need to define what CRS is. The definition that you'll see, the standard definition, is inflammation of the nose and sinuses characterized by at least two of the following symptoms for at least 12 weeks. Nasal blockage, nasal discharge, facial pain and pressure, or reduction or loss of smell. Phenotypically, there are two types, CRS without nasal polyps and CRS with nasal polyps. Characteristics of CRS without nasal polyps are a predominantly neutrophilic immune response. Patient symptoms tend to include facial pain and pressure, nasal obstruction, nasal discharge, whereas characteristics of CRS with nasal polyps predominantly an eosinophilic inflammatory immune response, particularly in the Western world. Endoscopic signs of nasal polyps are the presence of nasal polyps on a CT scan. They primarily complain of hyposmia or loss of smell. Many of them have asthma, and a large subset have aspirin hypersensitivity. What are nasal polyps? Nasal polyps are chronic inflammatory non-cancerous-like lesions that arise from the lining of the nasal sinuses or the nasal cavity. They may be associated with allergy or asthma or infection or cystic fibrosis or aspirin sensitivity. This is a slide showing all of the nasal polyps that were removed from one individual in a very extensive surgery. About 2/3 of patients who have nasal polyps will be colonized with Staphylococcus aureus. We'll talk about that more later. What is the prevalence of CRS with nasal polyps? Well, the worldwide prevalence is about 4%, with there being a slightly lower prevalence in Asia. About a quarter to a third of patients who have CRS have nasal polyps. Nasal polyps are more frequently found in males. However, the disease tends to be more severe in females. The average age of onset is in early 40s, with a diagnosis occurring somewhere between age 40 and 60 typically. There are a number of other comorbid conditions that will impact the pathophysiology of nasal polyps. Asthma and allergic rhinitis seem to be the most prevalent, but there are others such as infections, CF, AERD, anatomic deformities, and immunodeficiency. Having these comorbidities presents an obstacle for the optimal treatment outcomes. What is the impact of comorbid asthma on CRS with nasal polyps? Depending on the study, anywhere from 20 to 60% of patients with CRS with nasal polyps will have asthma. And when you have asthma and CRS with nasal polyps together, there is usually more severe asthma, more difficult to control asthma, more airway obstruction. Polyps tend to be more aggressive. There tends to be more recurrence, and the disease severity score is greater. This is in keeping with the unified airway hypothesis, which basically states that upper and lower airway diseases are the result of a single inflammatory process throughout the respiratory tract. But it's more complex than just the with or without polyps. It is more complex than just a phenotype. What we are realizing is that the clinical phenotype is not reflective of the underlying mechanism of inflammation. So these endotypes or mechanistic divisions are defined based on molecular components. But it's not a simple, straightforward, where one patient may have just one type of inflammation. There are three types of inflammation that can be found in CRS with or without nasal polyps. Type 1, which is mediated by ILC1 and Th1 cells, with the key inflammatory cytokine being interferon gamma and a neutrophilic infiltrate. Type 2, which is primarily mediated by ILC2 and Th2 cells, with key cytokines being IL-4, 5, and 13. Eosinophilic inflammation, release of cysteinoleukotrienes. 85% of people in the Western world that have nasal polyps have type 2 inflammation. And this type 2 inflammation tends to cause more severe disease, more recurrence, and more risk for asthma. Type 3 inflammation is that which is mediated by IL-17 and IL-22. It tends to be predominantly neutrophilic inflammation. What's key to know is that there may be more than one type of inflammation and there usually are more than one type of inflammation present in an individual patient. Another way to look at this is to say T2 high or Th2 dominant inflammation is present on one side, and T2 low, which is Th2 reduced or primarily neutrophilic or paucigranulocytic inflammation on the other side. And the way we divide these a lot, because there are new therapies primarily for Th2 high. So examples of T2 high asthma would be atopic or eosinophilic asthma. Eosinophilic CRS with nasal polyps would be an example of an upper airway inflammatory disease that's T2 high. Allergic fungal rhinosinusitis. And for T2 low, examples include T2 low asthma, CRS without nasal polyps, and non-eosinophilic CRS with nasal polyps. The T2-mediated inflammatory cascade is complex. It's orchestrated by a number of cells. If you follow along up top, we're looking at a sinonasal epithelium, which has predominantly epithelial cells, some goblet cells, and some specialized cells. What you see is that there are numerous insults that can occur to the sinonasal epithelium, such as bacteria, allergens, viruses, proteases, and these can break down. Once they break down the sinonasal epithelium, there are these epithelial cytokines, otherwise known as alarmins, TSLP, IL-33, and IL-25. They then relay that inflammatory signal to ILC2 cells, which bridge the gap between the innate immune system and the adaptive immune system. Dendritic cells stimulate Th2 and B cells. Mast cells release leukotrienes, which then stimulate ILC2 cells. And then type 2 cytokines are the ultimate product that are released, with IL-4 being primarily involved with Ige synthesis, with IL-13 being responsible for cell recruitment and fibrin remodeling, as well as mucus production, and IL-5 involved with stimulation of eosinophils. A specialized cell in the epithelium that was recently discovered was the solitary chemosensory cell, which tends to bridge innate and adaptive immunity. It's akin to the Tufts cell and in the GI tract, and about 1 out of every 100 epithelial cells is a solitary chemosensory cell. It responds to noxious stimuli. It will release antimicrobial peptides when it's activated, sort of like a bitter taste receptor in the sinuses. It has a neurological connection, neuropeptide release. It's the primary source of IL-25 release, which stimulates ILC2 cells to release IL-13 and IL-5, and IL-13 feeds back on the solitary chemosensory cell, promoting expansion of those cells. And also IL-5, as we talked about, stimulates eosinophil proliferation. So here's a model of how we believe nasal polyps form. This is a normal nasal mucosa, which is colonized with normal amounts of microbes. And you see here submucosal glands and some scattered inflammatory cells. When the epithelium is breached, in this case by a increased abundance and a decreased diversity of microbes, but we also showed in the previous slide other stimuli that can break down epithelium. Once that occurs, and then you get the secondary signaling from epithelial cytokines, you'll have this inflammatory reaction with recruitment of inflammatory cells into the submucosa. Further inflammatory cells will come into the submucosa, and IL-13 will stimulate fibrin cross-linking, which causes remodeling. And you start seeing some tissue fluid accumulating, and the remodeling begins. Oops, sorry, we're going forward. Okay. And here's a nasal polyp that's fully formed. You see invagination of the epithelium. Inside the nasal polyp, lots of inflammatory cells, cross-linked fibrin, and tissue fluid. Loss of submucosal glands, and this outpouching is basically what we believe is how a nasal polyp forms. Everyone gives the most credit to eosinophils, but it's really multiple types of immune cells that actually play a role in a polyp. And so this is demonstrated by this experiment where nasal polyp tissue sections were taken before and 6 months after depletion of blood and tissue eosinophils by dexpramipixole. And so what you see is that on the left, you see the panel that's rich in eosinophils. On the right, a depleted polyp that still has maintained its size. The polyp has not reduced in size when eosinophils were eliminated. And so a lot of other things are occurring, like remodeling and other inflammatory cells. So the eosinophil is not the sole cell involved. I mentioned earlier that Staphylococcus aureus plays a role primarily as a superantigen by releasing enterotoxins that actually damage the epithelial barrier and stimulate the type 2 immune response. And so this further keeps the process going, and about 2/3 of patients who have CRS with nasal polyps are colonized with Staph aureus. And so this can become a difficult cycle to break. The preferred method for diagnosing nasal polyps is nasal endoscopy, because it allows you to look at the middle meatus as well as whether there's any mucosal obstruction. You could distinguish a polyp from a turbinate. and you're able to score both sides with various scoring systems. Most of them are 0 to 4, with 0 being no polyps and 4 being complete nasal cavity obstruction. Anterior rhinoscopy is usually a first step, primarily in the primary care setting. It's inadequate because all you can really observe are large polyps like grade 3 and grade 4 polyps. Imaging is also used, with the CT scan being the imaging technique of choice, usually used for visualization. As you can see, CRS shows up as gray area, the paranasal sinuses. Oftentimes this is used for surgical planning or when there may be unilateral signs or any other red flags, which we'll show you in a moment. The MRI may be used when you have unilateral polyps or when you're considering intracranial extension or neoplasia. I have listed for you the major endotypes of CRS with nasal polyps. The most common are allergic fungal rhinosinusitis, particularly prevalent in the South, aspirin-exacerbated respiratory disease, or what used to be called Samter's triad, a newly described entity called central compartment atopic disease, and garden variety eosinophilic CRS with nasal polyps. Less commonly, but also should be kept in a differential diagnosis, EGPA, which includes a systemic vasculitis, cystic fibrosis, primary ciliary dyskinesia. These two processes are primarily neutrophilic, and non-eosinophilic CRS with nasal polyps or neutrophilic polyps, which are a little more common in Asia than they are in the United States. Bent and Kuhn were two rhinologists that came up with criteria for allergic fungal rhinosinusitis. The major criteria, all 5 of them need to be fulfilled to make a diagnosis. You need type 1 hypersensitivity to fungi by either skin test or RAS testing, nasal polyps, characteristic CT findings of hyperdensities, eosinophilic mucin with non-invasive fungi, which are positive on fungal stain. Fungal culture is less sensitive. Asthma may or may not be present. Unilateral disease is common. Bony erosion is common. Charcot-Lyting crystals may be seen, and most patients will have serum eosinophilia. These are minor criteria. Here is a CT scan of very far advanced allergic fungal rhinosinusitis, showing hyperdensities, showing bony erosion into the orbit. This patient has proptosis. It also, on the right, you see intracranial extension of polyps. And so the hyperdensities, the breakdown of bone, and this is a rather severe and can be a destructive form of CRS with nasal polyp. And you see allergic mucin, eosinophilic mucin, with occasional Charcot-Lyting crystals on the left, and on the right, you'll see occasional fungal hyphae, with about 80% of cases in the United States being associated with Aspergillus species, primarily Aspergillus fumigatus. Aspirin-exacerbated respiratory disease, or AERD, is characterized by eosinophilic CRS with nasal polyps and asthma. Patients have characteristic aspirin or NSAID-induced rhinitis and asthma attacks. They often have very extensive pansinusitis, and this is a progressive inflammatory disease even when patients avoid NSAIDs and aspirin. So it's not caused by aspirin or NSAIDs. Additionally, these polyps tend to regrow very quickly after surgery. Many patients have peripheral blood eosinophilia in the range of 10 to 15%, and nasal polyp tissue eosinophilia usually greater than 100 per high-powered field. Many of them, the majority of them, will have respiratory reactions when they consume alcohol, particularly red wine and beer. This is mediated primarily by polyphenols. Part of the pathophysiology of AERD is an imbalance between prostaglandins and leukotrienes. And what you see is at baseline, these patients have high levels of leukotrienes and low levels of COX-2 and prostaglandin E2, which have a negative effect on leukotriene pathway. And then when you have COX-1 inhibition by an NSAID, you will have a further reduction of prostaglandin E2 and its receptor, and then you'll have further propagation of leukotrienes. So this is a dysregulation of eicosanoids. In addition, On the top panel, you'll see that there's the same type of breakdown of the epithelium with a type 2 inflammatory process, and leukotrienes coming in and also stimulating the solitary chemosensory cell to stimulate further positive feedback on the epithelium. In addition, in panel B, you see that a lot of patients will have these granulocyte platelet aggregates, which also are factories for producing large amounts of leukotrienes. The diagnosis is clinical in most patients. Most patients CRS nasal polyps, asthma, and a history of a reaction to NSAIDs. If they have had 2 or more reactions, you have about a 90% positive predicted value. If you've had 1 serious reaction, it's about 100%. And if you're not clear, if there's doubt about the history or the patient does not ingest NSAIDs, you will have to do a aspirin challenge to get a definitive diagnosis. CCAD, or central compartment atopic disease, was described by the group at Emory. It is primarily representative of isolated polypoid changes in the middle turbinate, and these have a very high association with inhalant allergen. And these patients, this probably represents a local inhalant allergy process that affects the central nasal structures of ethmoid origin, including the entire central sinonasal compartment, the middle and superior turbs, the posterior superior nasal septum, sparing the lateral sinus mucosa. And so allergy management tends to work well in these patients once their primary condition is cleared. As you can see endoscopically in panel A, they have nasal polyps, which are centrally located, primarily near the septum, as well as the superior turbinate. And in panel B, you see radiographically, primarily central compartment disease affecting the middle turbinate and the ethmoid structures. And here's a more advanced form of CCAD, again, primarily affecting the central ethmoid structures. Okay, so what are the primary principles of nasal polyp management? Well, the goals of management are based on symptom severity and the presence or absence of polyps. We want to reduce patients' polyp size, symptom relief, quality of life improvement, and prevent recurrence. Right now, we don't have biomarkers to drive treatment decisions. I believe in the future we will. Practitioners who follow nasal polyp patients should be aware of these alarm symptoms, and these are the reasons to proceed with immediate referral. And these would be situations like periorbital edema, proptosis, and any ophthalmic symptoms, severe headaches, frontal bossing, signs of sepsis or meningitis, neurological signs or symptoms, unilateral polyps, excessive bleeding or crusting, or patients smelling really horrible smells, called hyposmia. Traditional therapy has always been oral steroids to start with in patients who were not operated on to try to reduce the size of nasal polyps, and they've been shown to do so. Treatment exacerbations is often with oral corticosteroids, but as we all know, the long-term treatment with oral corticosteroids is fraught with unacceptable side effects, and so it's sort of a double-edged sword. The cornerstone of maintenance therapy has always been topical nasal corticosteroids, intranasal corticosteroids. Unfortunately, the currently available aqueous nasal sprays are very ineffective because they only reach the inferior turbinates. There is a newer device that's about 4 or 5 years old that's called the Enhanced Delivery System Spray for fluticasone, EDS flu. It improved delivery to the middle meatus in a non-operated patient, and it reaches the frontal recess in patients who've had draft 2B or 3 surgeries. In other words, they've had surgery on the frontal sinus or frontal recess. It's FDA approved for nasal polyps not responsive to intranasal corticosteroid sprays. As you can see, the device has both a mouthpiece as well as a nasal piece. The nasal end will stent the nasal valve, and patients blow into the device as they spray it into their nose. the spray you see on the far right panel, the spray will reach very superiorly and posteriorly in the nasal cavity because the palate is elevated and it's closed off during the exhalation maneuver. In the middle panel, you see the typical deposition of an aqueous nasal spray, primarily in the lower part of the nasal cavity. For over 15 years, practitioners have used off-label, that is, high-volume steroid saline irrigations, and these have been shown to have high deposition into the nasal cavity, particularly postoperatively, and are superior to nasal sprays. Some practitioners have used installations or drops, which are concentrated solutions that are used in patients in various poses and various positions to reach various sinuses. The benefit of sinus irrigation is that it removes mucus, debris, allergens, other pro-inflammatory molecules. That retrograde flow penetrates more deeply into the sinuses, and sinus surgery delivers improved topical therapy to the sinuses, improved topical penetration. And so the goals of sinus surgery for polyps should be to remove the lamellae of the lateral nasal wall, as you see here on the left panel. When we remove these panels, we remove these lamellae without getting into the eye or brain, and that's the key of what the surgeon needs to do. There's effective therapy there that will be removing not only increasing the topical ability to reach higher up into the sinuses, but also removing surface area, which is a nidus for polyp regrowth. And on this slide, there's a video that should be showing. See if that comes up. There's the video. I hope everyone's seeing that. And if you just do an ethmoidectomy, that's a draft 1. A draft 2 is where you're opening up the frontal recess to get into the frontal sinus. And a draft 3 is when you are taking away the frontal intersinus septum between the left and right frontal sinuses. And there's a draft 3 on a coronal view. And you can see that sometimes that's used in refractory cases for patients who need better deposition of topical therapy. Of course, this patient is very happy. It's the ideal post-surgical cavity, what it looks like radiographically. This patient has some mild symptoms in the middle, and on the far right, you can see this patient's not doing very well. The role of antibiotics in CRS with nasal polyp management. There's still a lot of evolving data here. There's some controversy. Antibiotics with anti-inflammatory properties have recently been shown to have some effects, particularly in patients who have refractory disease that are not responsive to topical steroids, or may be compounded by colonization with Staph aureus. Doxycycline and macrolide antibiotics may play a role in this therapy. We've had several patients respond to that therapy. Again, this is off-label therapy. Patients may be treated with antibiotics short-term or long-term. Short-term for acute exacerbations of infectious exacerbations. Aspirin desensitization therapy has a long history of over 40 years and 24 studies, 4 double-blinded, almost all of them showing that they recommend desensitization in a systematic review. Polyp size, polyp recurrence, nasal symptom scores, sense of smell, rhinosinusitis episodes, systemic and inhaled corticosteroid use are improved when patients were desensitized and they stayed on long-term therapy. So this is a helpful adjunct, particularly in patients only in patients with AERD. These are the 3 FDA-approved biologics for CRS with nasal polyps, and Dr. Wexler is going to discuss these in detail. So I want to just mention their names: dupilumab, omalizumab, and mepolizumab. And Dr. Wexler will, again, discuss those in more detail. I show this slide to just give the audience an idea of what the costs, what the annual wholesale prices of these biologics are compared to some other traditional therapies. And unfortunately, this is what often ends up being the reason why these therapies are used as salvage as opposed to initial therapies. Last year, myself, amongst 12 other allergists and rhinologists, convened a interdisciplinary expert panel to try to agree on what we would do in cases of CRS with nasal polyps and how we would approach it. We've already discussed how we look at the cardinal symptoms, how we would get subjective quality of life measures such as SNOT-22 scores. We would want to see objective findings such as rhinoscopy, endoscopy scores, or CT. Patients are often started on intranasal corticosteroid sprays and short bursts of oral corticosteroids if they're not contraindicated. Patients should be reassessed about a month later to see if there's any improvement. If they have persistence of symptoms and recurrent disease, we may want to try to endotype them, considering allergy testing, aspirin challenges, CBCs with diffs to look at eosinophilia, IgE levels, and if there's systemic vasculitis signs or symptoms suspected, we may be looking at ANCA. Next, we may want to consider an enhanced delivery system of steroid or another short burst of oral corticosteroids. But if the patient is refractory to all this, we're going to escalate to the next level. And this is what Dr. Wexler is going to be speaking mostly about today. Just going to give you an outline of what we suggested. The majority of patients will end up with sinus surgery, particularly with advanced disease. A minority of patients are going to have either a contraindication to surgery, they may decline surgery, their asthma may be so severe or despite therapy, or they may have oral corticosteroid-dependent asthma. And so therefore, in these cases, we may go right to a biologic much earlier than we would in the majority of cases. In the majority of situations after sinus surgery, as I mentioned, postoperative management is primarily that of topical corticosteroids, whether you use the enhanced delivery system, sinus irrigations, etc. And of course, if this is enough, if this works, then basically that's great, and that patient might be very happy using topical therapy, and that's a very safe long-term way to go. But if patients have symptoms that persist despite appropriate sinus therapy, sinus surgery followed by topical steroid therapy, then we would want to possibly consider a multi-specialty or comprehensive approach for management, of course, involving the patient in shared decision-making. Here's where we would consider, if a patient has severe asthma, perhaps a biologic. And of course, we would reassess those patients at the end of 6 months to see if that was working. If the patient did not have an adequate surgery, we may want to consider a revision surgery. If the patient has AERD and has no contraindications to aspirin therapy, we may want to consider aspirin desensitization and long-term therapy and assess the response in 6 months. If the patient has localized disease that's difficult to treat, we may want to consider a steroid sinus implant. We may have to consider longer courses of oral corticosteroids, particularly postoperatively. And again, if the patient still has persistent disease despite these interventions, we may want to go back and reconsider a combination of these interventions. So that's the end of my section. We're going to look at the post-test with a question we talked about earlier in the pre-test. I'm going to read it again. And that is, which cell is most important to development of type 2 CRS with nasal polyps? Eosinophils, ILC2 cells, Th2 cells, mast cells, or no one particular cell, rather a coordination of multiple cells? Okay, well, now I'm going to turn this over to Dr. Wexler, who will take you through biologics. Actually, the audience response to this question. We should look at that. Is that available to us? Okay, now we'll go over. We'll go to Dr. Wexler.
Thank you so much. That was an incredible presentation on chronic rhinosinusitis with nasal polyps, and I'd like to thank you, John, for educating the audience, educating me. One of my major disclosures is that I'm a pulmonologist. And while I see a ton of chronic rhinosinusitis with nasal polyps, and I have expertise in the biologics, I really defer to you in terms of the surgical management and day-to-day management of chronic rhinosinusitis polyps. So I'm a pulmonologist, and I see a lot of CRS with NP. It's a major complicating factor, as John had alluded to, and it's an important comorbidity in patients with asthma and patients with other type 2 diseases. So before we get started with my presentation, let's go through another clinical vignette. This is a 42-year-old woman who presents with poorly controlled CRS with NP and comorbid asthma, who, despite nasal inhaled corticosteroids and nasal saline irrigation, and despite the fact that she had 3 oral prednisone courses within the last year, continues to have symptoms. Her serum Ige is 400 international units. Her blood eosinophil count is 430 cells per microliter, and she's treated with an treatment with an anti-IL-4/13 therapy, dupilumab, is expected to reduce all of the following except need for further surgical intervention, nasal polyp score, blood eosinophil count, Lund-Mackay sinus CT, SNOT-22 score. I'll give you a moment to answer the question, and we'll discuss these during the post-test evaluation. Again, treatment with anti-IL-4/13 therapy with dupilumab is expected to reduce all of the following except. Oh, now you have a moment to answer the question, sorry. Okay. All right. Well, I think we've given people enough time. We'll get back to that question towards the end. So I was asked to speak about the efficacy and safety of biologics for chronic rhinosinusitis with nasal polyps. And I think it's very difficult to discuss this topic without sort of reviewing some of what John just talked about, the importance of endotyping and the importance of understanding what type of chronic rhinosinusitis with nasal polyps a patient has. What's the underlying mechanism of disease? What might we want to target in terms of our understanding of patients, and which agents might we consider? Now, it's a very exciting time in the management of CRS with NP, as it is for asthma and many other diseases. We now have at our disposal several biologics, 3 biologics, as John mentioned, that are approved for CRS with NP. In asthma, we now have several new biologics. We have, I believe, 6 biologics now that have been approved for CRS, for asthma and patients with severe asthma. So I'll just review a couple of points, the key points that John made. First of all, I think it's important to recognize CRS with NP versus CRS without NP. It's important to do a formal evaluation. If you're an ENT doc, of course, you're going to be taking a look in with rhinoscopy. You should be also evaluating by imaging. And it's important to evaluate for CRS with NP and CRS without NP. And the reason for that is because CRS with NP continues to have significant impact. There's significant prevalence. It's more frequent than diabetes. It causes significant deleterious effects on health with poor quality of life. There's impacts on the lower airways, particularly as an asthmatologist. I see a lot of CRS with NP that affects the lower airways. And there's also many complications of having CRS, and also a lot of use of antibiotics, use of corticosteroids that can have significant impact on long-term health and consequences. Chronic use of oral corticosteroids for asthma and for chronic rhinosinusitis with nasal polyps can have significant impact overall. Plus, there's significant healthcare resource utilization and a significant impact on quality of life. And John mentioned type 2 inflammation, and I want to just touch upon the fact that there's a long list of type 2 diseases. Type 2 diseases are diseases that are affected by interleukin-4, interleukin-5, and interleukin-13. And while we chronically think or historically thought of asthma as one of the first diseases that we've endotyped and characterized by prevalence and utilization of these cytokines and activity of these cytokines. There's a long list of other type 2 mediated diseases, including atopic dermatitis, eosinophilic esophagitis, and chronic rhinosinusitis with nasal polyps. All of these seem to cluster together, and it tells us that there's a common pathophysiology. Part of the chronic pathophysiology of these diseases is really all of the cells that are involved, whether it's eosinophils, whether it's mast cells, whether it's ILC2 cells, and all the different cytokines that we see, IL-4, 5, and 13, that can play a role not just in the upper airway, as we're going to discuss in terms of allergic rhinitis, chronic rhinosinusitis, with and without nasal polyp, but also in the lower airways with regard to asthma and COPD. And that's why we need to understand what's going on. We need to be able to recognize the eosinophilia. And if you take a photomicrograph biopsy of a nasal polyp, you'll see a significant amount of eosinophilic inflammation surrounding a cap, surrounding a central pseudocyst. And that is one of the key hallmarks of eosinophilic type 2 inflammation in these patients. The other important character of type 2 inflammation is the barrier dysfunction, the immune dysregulation, the microbiome imbalance, and all this is mediated by several different cytokines. And so it's important to recognize the types of cytokines that are going on. First of all, there's environmental factors that are common across all these entities, whether it's asthma, whether it's CRSwNP. You get a significant amount of epithelial barrier disruption when there's interaction between the environment, for instance, viruses, allergens, bacteria, and fungi, and with the epithelium. That leads to some barrier dysfunction that can be potentiated by activity of several of these cytokines. Both IL-4 and IL-13 are associated with increased barrier disruption, and that can allow for increased allergen entry into the airways, whether it's the upper airways or the lower airways, and that results in immune dysregulation and increasing type 2 inflammation with activity of IL-4, 5, and 13. IL-4 is historically recognized as a key cytokine that's involved in eosinophilic inflammation. So IL-5 activates eosinophils and allows for eosinophils to traffic into the tissue. IL-4 is involved in B cell switching and IgE production. And IgE is involved in mast cell activity and release of an activation of mast cells with release of mediators, including leukotrienes, histamines, and prostaglandins. IL-13 is involved in goblet cell hyperplasia and mucus production and tissue remodeling. So why am I telling you all this? Well, all of these cytokines and all these features are present in asthma, they're present in CRSwNP. And if we can identify the key underlying mechanism of the pathophysiology in a given patient, then perhaps we can target those patients with targeted therapies, with targeted biologics that can treat these patients with CRSwNP and mitigate some of the symptoms. Similar to asthma, similar to CRS, you can see that there's commonalities. There's the epithelial barrier dysfunction I mentioned, tissue remodeling, mucociliary dysfunction and mucus production, microbiome alterations, IgE production, eosinophilia, and in asthma, we also see smooth muscle hyperreactivity. And these are common across some of the other type 2 diseases, including allergic rhinitis, atopic dermatitis, and eosinophilic esophagitis. So the reason I tell you this is so that you can look for these key features when you're seeing your patients with chronic rhinosinusitis. Look for the eosinophilia, look for evidence of IgE disease, look for mucus production in these patients, and try to identify on biopsies evidence of tissue remodeling, thickened basement membrane, and any of the key features, including some potential for tissue remodeling. The reason you want to look for it is because these are all signs of type 2 inflammation and activity of type 2 cytokines. Now, we have several biologics that are in the type 2 treatment landscape, and we have some that are approved for asthma, we have some that are approved for chronic rhinosinusitis, and then there's also ones that are being evaluated in eosinophilic esophagitis and in atopic dermatitis. Currently, when we think about the type 2 therapies, we think about anti-Ige therapy with omalizumab, approved in 2003 for asthma, and just most recently approved for chronic rhinosinusitis with nasal polyps. Dupilumab blocks IL-4 and IL-13, approved for atopic dermatitis, approved for asthma, and also more recently approved for chronic rhinosinusitis with nasal polyps. And then lastly, the anti-IL-5s, mepolizumab and benralizumab, that target the eosinophil. Again, mepolizumab has been approved for chronic sinusitis with nasal polyps. Benralizumab, the phase 3 studies are complete, and we expect there to be approval for that in the near future. The point here is that across all these diseases, you should be asking about all these comorbidities because it may help you decide which treatment you utilize for a given patient. So we've already talked, John already spoke about the initial management, and in the absence of complications of severe illness, again, use of nasal and oral corticosteroids, oral antibiotics, short courses for some patients, topical intranasal corticosteroids indicated for most patients. Usually medical therapy is the way to start, and then surgical therapy is when there's refractory or persistent disease. The question becomes, well, what if there isn't success? Well, there's over 500,000 sinus surgeries per year in the United States, and they often are quite effective in terms of mitigating chronic rhinosinusitis symptoms. One of the issues, however, is there's still some room for improvement. Polyp recurrence following sinus surgery is common, and 35% of patients have polyp recurrence by 6 months, and 70-80% have signs of mucosal edema by 6 months. The need for second surgery within 5 years for 20% of patients who receive surgical treatment. So it tells me that sinus surgery is an effective modality for many patients, but the problem is that there's still some recurrence. And we know that polyp recurrence is increased in patients with other type 2 diseases, in patients with asthma, and aspirin sensitivity. There is increased risk of surgical recurrence and polyp recurrence for these patients. So for these refractory patients who've undergone surgery and who continue to have persistent disease, what we currently have available, or up until recently, we continued to use recurrent surgery, topical and oral corticosteroids. But perhaps that's where the role of biologics may fit in. For these patients who are failures, patients who continue to have continued symptoms of chronic rhinosinusitis with nasal polyps. So what is the status of current biologic therapies for chronic rhinosinusitis with nasal polyps? As you can see in the top row, we currently have 3 therapies that have been approved. Omalizumab, which is an IgE monoclonal antibody, mepolizumab, which is an anti-IL-5 monoclonal antibody, and to the far right, dupilumab, which is an anti-IL-4 and IL-13 therapy. All 3 of these therapies have been approved based on large phase 3 studies that showed significant efficacy. In terms of the means of administration, omalizumab, mepolizumab, and dupilumab are all self-administered. They can be administered at home or in a healthcare setting. And there are differences in terms of the frequency. Omalizumab is administered every 2 to 4 weeks, mepolizumab every 4 weeks, and dupilumab every 2 weeks for nasal polyps and chronic rhinosinusitis. 2 other therapies in the middle there. Reslizumab is an IV preparation. It's approved in asthma, but it's only in early studies for chronic rhinosinusitis with nasal polyps. And then there's benralizumab, which is currently in phase 3. It's actually at the FDA for evaluation for chronic sinusitis with nasal polyps. One of the advantages of benralizumab, again in an off-label manner for CRSwNP, is that after the first 3 doses, it's administered every 8 weeks. So that's the landscape. Why don't we review each of these therapies and what the data are for their approval? The first biologic that was approved for chronic rhinosinusitis with nasal polyps is dupilumab. Dupilumab is a monoclonal antibody that binds the IL-4 receptor. And the IL-4 receptor is the binding site for both interleukin-4 and interleukin-13. So when you block IL-4 with the IL-4 receptor with dupilumab, you block IL-4 and IL-13. Dupilumab was initially approved in 2017 for atopic dermatitis. In 2018, it was approved for asthma. And now let's review the data for its efficacy in patients with chronic rhinosinusitis with nasal polyps. The phase 3 study with dupilumab was published in 2019 by Claude Backert and colleagues. And there were two studies, the Sinus 24 study and the Sinus 52 study. The Sinus 24 study randomized patients to dupilumab or placebo for 24 weeks. And the Sinus 52 study randomized patients for 52 weeks with dupilumab using a dose of 300 milligrams. In asthma, both the 200 and 300 milligram dosing were approved for chronic rhinosinusitis nasal polyps. It's a 300 milligram dosing. On the right-hand side, you can see the endpoints, which we'll review now. So the co-primary endpoints was to evaluate the efficacy of dupilumab 300 milligrams compared with placebo on background therapy. And one of the goals was to evaluate nasal congestion and obstruction severity and change from baseline at week 24 in terms of endoscopic nasal polyp score. The endoscopic nasal polyp score ranges from 0 to 4, no polyps being 0, severe disease being 4. And you can see in this cartoon diagram that there are no polyps versus having small polyps, polyps reaching the lower border of the middle turbinate, larger polyps reaching the lower border of the inferior turbinate, and large polyps causing complete obstruction. So this is an important score. It's identified, again, there's some subjectivity by the physician, but it's generally well appreciated as an important score, nasal polyp score, that can help us identify response to specific therapy. Another key secondary clinical outcome was the CT scan score, the Lund-Mackay score, which also evaluates a variety of different opacifications on the left and right side of the sinuses, looking at the maxillary, the anterior ethmoids, posterior ethmoids, the sphenoids, the frontal region, and the osteomeatal complex. The score ranges from 0 to 9, and it's a composite score that evaluates each of these different domains. The other endpoints that were looked at include daily severity loss of smell scores, the University of Pennsylvania smell identification test, UPSIT, which I'm sure John was probably responsible for, and the 22-item sinonasal snot score. So those were the key outcomes. So how did dupilumab do? Again, dupilumab blocks interleukin 4 and 13, and it demonstrated significant efficacy in both the Sinus 24 study as well as the Sinus 52 study in terms of improvement of the nasal polyp score, in terms of improvement in nasal congestion, and in terms of improvement in the Lund-Mackay CT scan score. All of these demonstrated significant efficacy both at 24 weeks and at 52 weeks that was significantly different compared to placebo. Therefore, this translates to significant improvement in symptoms. Patients feel better, they can breathe better, and they can smell better. Nasal polyp scores actually started improving right from the beginning of the study. Both at the 8-week time point, you can see significant improvement that was sustained throughout the 24 weeks. In the first study, in the Sinus 24 study, when patients came off of therapy, you can see that their symptom scores, their nasal polyp scores gradually got worse. In the 52-week study, again, you see improvement as early as at 4 weeks, sustained improvement out to 24 weeks, and then continued improvement out to 52 weeks when patients were continuing to get this therapy. So significant improvement in nasal polyp scores in these patients on the order of around 2 points or so compared to placebo, which is significant, clinically significant. And you can also see that there's significant improvement in the nasal polyps endoscopically when you look at these patients endoscopically. I'm not sure if I can, video clip is working. Let's see if that's working. I don't think that the video is working, but suffice it to say, and you can see just from the figure here, that there's significant improvement in nasal polyps pre to post treatment. Oh, there we go. Actually, I just saw it a second ago. I think it just took a while to. Compared to before the study, patients who received dupilumab had significant improvement in their nasal polyps. There we go. Okay, so one of the other things that was looked at was the responder analysis. What proportion of patients had significant improvement by at least 1 point or by at least 2 points in their nasal polyp score from baseline? As you can see, 65% of patients improved by at least 1 point, 46 by at least 2 points, compared to placebo, where it was just 5 to 17 points in the Sinus 24 study. And when you look at week 24 in the Sinus 52 study, again, very similar results. Almost half to 2/3 of patients had significant improvements in their nasal polyp scores, and this was observed throughout the study. Nasal congestion, another important symptom in patients with chronic rhinosinusitis, improved early on and was sustained throughout each of the studies to 24 weeks in the Sinus 24 study, and in the Sinus 52 study, it was sustained out to 52 weeks. So significant in that outcome as well. And then in terms of the Lung-Mackay score, again, I demonstrated already there's significant improvement, but both in the Sinus 24 and in the Sinus 52, dupilumab outperformed placebo. Other key secondary endpoints included total symptom scores, the UPSIT score, the loss of smell score, and the SNOT-22 score. All of these achieved statistical significance in both the Sinus 24 study as well as in the Sinus 52 study. And I think something that's important to patients that they really remark on when they regain their sense of smell, the smell scores that were attained early on in these patients, sustained throughout the study. And another important component was that dupilumab reduced the proportion of patients who used systemic corticosteroids for any reason, or who had sinonasal surgery during the study. Only 12% of patients who were on dupilumab versus 42% of patients on placebo ended up either requiring systemic corticosteroids or having sinonasal surgery during the study. Skip over that. So from what I've told you so far, I guess you can gather that dupilumab was very effective, and it was finally approved for CRSwNP in June of 2019. Let's move on to therapy. So what's the role of IgE? I've shown you what we call confusograms showing all these different arrows going in different directions, which I think highlights the complexity of chronic rhinosinusitis nasal polyps. So what's the role of IgE? Well, IgE is produced in response to different stimuli. Again, at the epithelial layer, there are bacteria, fungi, allergens, all of which epithelial cells and dendritic cells to produce a variety of different alarmins that include IL-25, TSLP, and IL-33. These epithelial cytokines play an important role in activating ILC2 cells and Th2 cells to produce a variety, to activate different pathways. IL-4 plays an important role in B cell production of IgE, and IgE binds to mast cells, and in the presence of aeroallergens, IgE bound to an aeroallergen on the mast cell can cause the mast cell to degranulate and release its mediators, histamines and leukotrienes and tryptases and glandins. So the role of anti-IgE in chronic rhinosinusitis nasal polyps is to bind up the IgE, to prevent it from binding to the mast cell, to prevent the mast cell from degranulating and releasing all of the mediators, histamines and leukotrienes and tryptases and prostaglandins that play a role in terms of mediating edema, vasodilation, and recruitment of eosinophils, basophils, and other inflammatory cells to the airways. So anti-Ige therapy with omalizumab was studied in a 24-week trial compared to placebo, in which patients received intranasal corticosteroids as background therapy. And then there was a follow-up period at the end of the study. And what was demonstrated in this 134 patient study, 138 patients in the Polyp 1 study, 127 patients in the Polyp 2 studies. There were 2 replicate phase 3 studies. In the first study, the Polyp 1 study, 72 patients received omalizumab, 66 patients received placebo. In the second study, 62 patients received omalizumab and 72 patients received placebo. And they received treatment for 24 weeks. And what was observed was that omalizumab significantly improved endoscopic, clinical, and patient-reported outcomes versus placebo. When looking at improved nasal polyp scores in both the Polyp 1 versus Polyp 2 study, you can see that there was significant benefit with omalizumab versus placebo, improved nasal congestion scores, and improved disease-related quality of life scores in terms of the SNOT-22 score. Let's dig into these data a little bit more closely. They were published last in the Journal of Allergy and Clinical Immunology. Omalizumab, in terms of nasal polyp score and nasal congestion score, you can see in both the Polyp 1 study as well as in the Polyp 2 study, patients who received omalizumab had a significant improvement in terms of their nasal polyp score on the left-hand side compared to placebo, where there was only minimal significant benefit. On the right-hand side, you can see that in both the Polyp 1 and in the Polyp 2 study, again, omalizumab had a significant improvement in terms of nasal congestion scores. These were published last year by Gavert and colleagues. In terms of the proportion of patients with improved symptoms, you can see that omalizumab also fared very well when looking at the proportion of patients who had significant improvement, a 2-point improvement in nasal polyp score, a 1-point improvement in nasal polyp score, and a 1-point improvement in nasal congestion score. Almost twice as many patients with omalizumab compared to placebo had improvements in each of these different metrics, which suggests significant efficacy with regard to all of these important metrics that are important to patients. Other important outcomes that were observed in the Polyp 1 and Polyp 2 score include improvement in the SNOT-22 score in the upper left-hand side, improvement in the UPSID in the upper right-hand side, and in terms of nasal symptom scores, again, significant improvement in 2 replicate studies compared to placebo. All of these were statistically significant. So what I've shown you so far is that blocking IL-4 receptor is effective in terms of improving outcomes, and blocking IgE is important in improving outcomes. And just as dupilumab was approved for chronic rhinosinusitis with nasal polyps in 2019, omalizumab was approved for chronic rhinosinusitis with nasal polyps in December of 2020. So we now have a little bit more of a year of experience demonstrating its efficacy as well. Well, what about targeting the eosinophils specifically? Well, in terms of targeting the eosinophils, you could target interleukin-5, or you could target the interleukin-5 receptor. Both of these therapies have been, all 3 of these therapies have been approved for eosinophilic asthma. Mepolizumab, which is administered subcutaneously, binds up IL-5 and prevents it from binding to the IL-5 receptor, and prevents IL-5 from causing eosinophils to mature, activate, and degranulate. It's administered subcutaneously on a monthly basis. Reslizumab is administered intravenously. It's not yet approved for chronic rhinosinusitis with nasal polyps, nor is benralizumab, which binds the IL-5 receptor. But what's interesting about benralizumab is that when it binds the IL-5 receptor, not only does it prevent IL-5 from binding and activating the eosinophils, it also gets recognized as a foreign body and ends up having the eosinophils being killed off because the benralizumab is recognized as foreign. And it results in apoptosis through an antibody-dependent cell-mediated cytotoxic effect. So, mepolizumab is the only one of these 3 that is currently approved. This is based on several different studies. The first study was a small study in which mepolizumab reduced the need for surgery in severe nasal polyposis. This was a randomized study, smaller study, that showed that 30% of patients with mepolizumab versus 10% of patients with placebo didn't require follow-up surgery. It also showed that there was an improvement in nasal symptom scores and nasal polyp scores. This was a relatively small study, and it was done as a phase 2 study before the phase 3 studies that were done. The phase 3 study, SYNAPSE, was a randomized, double-blind, placebo-controlled trial in which 407 patients were randomized to receive mepolizumab versus placebo for 52 weeks. In this study, just as with omalizumab, just as with dupilumab, nasal polyp score improved, nasal obstruction improved by a visual analog scale, and there was no significant difference in terms of adverse effects. In a very recently published study in January of this year by Klaus Backert and colleagues in the Journal of Allergy and Clinical Immunology, mepolizumab for chronic rhinosinusitis with nasal polyps showed efficacy in a variety of different patients, regardless of comorbidity and regardless of blood eosinophil count. The proportion of patients with greater than 1 point improvement in nasal polyp score was higher with mepolizumab versus placebo in asthma patients, 53% versus 30%, in AERD patients, 51% versus 21%, in patients with low eosinophils. So even though mepolizumab targets eosinophilic patients, it was effective in nasal polyps patients, even in patients who had low blood eosinophil counts, 55% versus 31%. And obviously in patients who had eosinophil counts greater than 150 and greater than 300. What was also interesting was that similar trends were observed in patients without comorbid asthma or AERD. And I think that tells us, again, we need to look at the patient itself, himself or herself, and try to identify what else could be going on in those kinds of patients with asthma. Based on these results, based on the SYNAPSE study, mepolizumab was approved for CRSwNP. It's the most recent therapy to be approved for that, and that was approved just 7 months ago in July of 2021. What about benralizumab? Well, it's not yet approved, but a phase 3 ASTRO study is complete, and so far, benralizumab has been shown to be effective. It's administered every 8 weeks, and compared to placebo, benralizumab decreased nasal polyp score, it decreased nasal blockage score as well, and there was no statistically significant difference between group differences in terms of time to first nasal surgery or SNOT-22. So that needs to be further evaluated. I know this is at the FDA, and just this morning I read that the FDA has requested more data with benralizumab studies. This was a 40-week study, which patients were given benralizumab after the first 3 doses every 8 weeks. So I've shared a lot of information. John has shared a lot of information. And I think we've talked about the complexity of nasal polyp patients and chronic rhinosinusitis patients. We've talked about the heterogeneity of these patients. We've talked about all of the underlying mechanisms of disease. In my section, I've shared with you that the biologics that we have available that have currently been approved really can provide a significant advance in the treatment options for patients with severe chronic rhinosinusitis with nasal polyps. They've been shown to improve nasal polyp burden. They've been shown to improve sinus opacification. They've been shown to improve symptoms. They've been shown to improve healthcare-related quality of life. They've been shown to improve sense of smell. They've been shown to reduce systemic corticosteroid use, and in patients with asthma as a comorbidity, shown to improve lung function and asthma control scores, and they're generally safe and well tolerated with low immunogenicity and no new adverse drug reactions. So in terms of thinking about how do we treat and approach patients and where do we use biologics, well, I think we start endotyping our patients, identifying which patients have type 2 features and non-type 2 features, which patients have chronic rhinosinusitis, nasal polyps, and without nasal polyps, which patients have asthma, and which patients don't have asthma, and then identify risks for these specific patients. For some patients who've got non-type 2 disease, certainly we can approach those patients earlier on with macrolides and with nasal corticosteroids. And surgery for many of them. And for some patients, biologics may be the way perhaps even before surgery. John mentioned already the costs associated with these therapies, $40,000 a year or so. And so that might be prohibitive for some patients and for some payers. On the other hand, the benefit that these patients have over the long term, the lack of need for recurrent sinus surgery, is important. It's important to remember that biologics have a rapid effect. They provide broad coverage of symptoms. They have a rapid effect in terms of smell, not necessarily related to obstruction. And we need to really evaluate how we're going to identify what are the selection criteria. We need to think about patient outreach initiatives, and we obviously need to educate physicians about who is the ideal patient. How do we decide which biologic to start first? How long should we treat a patient with a biologic? And what about recurrent nasal polyposis despite surgery and therapy? Is that the optimal time to try these therapies for our patients? We also need to ensure that patients demonstrate compliance with prior therapy before we initiate these things. And we also may consider a trial period to assess effectiveness. How long should we go with each of these therapies? When do we define failure? When do we stop? And are there any biomarkers or optimal patient profiles that are desirable for our patients? So thank you so much for your attention. Let's go back to our post-test clinical vignette. This was a 42-year-old woman who presents with poorly controlled CRS with nasal polyps, comorbid asthma, right nasal inhaled steroids, nasal saline irrigation. She's had 3 oral prednisone courses within the last year. Her Ig is 400. Her blood eosinophil count is 430. She gets treated with anti-413 with therapy with dupilumab. This is expected to resolve the following except. I think I need to push it right now. There we go. So treatment with dupilumab is expected to reduce all the following except need for further surgical intervention, nasal polyp score, blood eosinophil count, Lund-Mackay sinus CT score, and SNOT 22. Take a moment to answer. Okay, so, well, treatment with anti-413, the correct answer is answer C, which is blood eosinophil count. I didn't talk about this in the lecture, but I did mention the fact that treatment with dupilumab does reduce the need for further surgical intervention. It does reduce nasal polyp score. It does improve Lund-Mackay sinus CT score, and it improves SNOT 22 score. One thing that it does do is improve blood eosinophil counts. The reason for that is because dupilumab blocks IL-4 and 13 mediated trafficking of eosinophils into the tissue. So when you block trafficking of eosinophils into the tissue, the blood eosinophils actually go up. And so contrary to the anti-Iges, mepolizumab and benralizumab, which lower eosinophil counts to very low levels, with dupilumab, you actually see a slight increase in eosinophil counts, something that people observe, and it's something to be wary of, particularly patients who've got very high eosinophils to start with, who have got higher eosinophil counts above 1,000 to start with. For those patients in particular, you want to be cautious about using a drug like dupilumab and may consider one of the alternate treatment strategies. All right, now we have some time for questions.
Anyone wants to submit a question, now is the time.
So, John, why don't I just pose a question to you, which is, as a rhinologist, when do you consider using a biologic? Do you ever consider before surgery, or only after surgery has failed? What are your considerations?
Well, I'm actually an allergist who's in the rhinology division. I'm an allergist immunologist, but I will answer that question. Yeah, I mean, again, before surgery, the only time I'll consider it is a situation where there's strong comorbidities, multiple comorbidities, or the patient is not a good surgical candidate, or the patient refuses surgery. Okay, if they have severe asthma that's corticosteroid dependent, we're going to treat the asthma before we treat the upper airway and get that controlled. So from that standpoint, I think that would be where I would consider it before surgery. For most situations, we're going to try, again, all surgeries are not created equal. So what you need to know is you need to have, if you have polyp disease and if you're going to do a surgery, you can't just do a little mini polypectomy. It has to be a complete clean out. You have to have opening of the ethmoid partitions, eliminating of those. You need to open up the frontal sinus, and you basically need to open up the antrostomies to the point where topical therapy will actually get to the place you want it to go to. Otherwise, surgery is really ineffective. And so there's lots of different variants in surgery. The surgeons who have more advanced training, who do either rhinology fellowships or have a lot of experience with sinus surgeries, are more likely to do the types of surgeries that are going to be effective. So that's another issue. One surgeon said, well, biologics make a bad surgeon look like a good surgeon, and that they improve things, right? So, I think a lot depends on your surgeon and also the post-op management and the cooperation of the patient, which is very important. As you said before, compliance is important not only before you consider a biologic, but even after you start a biologic, as well as it is with topical steroids and anything else that you do. So those are my considerations.
Great points. Looks like we have a couple of questions that have come in. One question is what's the duration of treatment with biologics at this time? And when do you consider stopping? So I think it's very reasonable. I'm curious to hear what John has to say, but usually it takes a while to get sufficient blood levels of these biologics in one's system. I usually give a 4 to 6 month treatment period. And one of the key things that I want to identify is what was the reason that I started the biologic? And that's what I track. Is it because of congestion? Is it because of the lack of sense of smell? Is it because of frequent exacerbations? Is it because of the underlying asthma? What's the reason that I want to start a biologic? And usually I'll give a minimum of 6 months before I make an evaluation and see whatever the metric that made me wanted to start a biologic. That's what I do. That's what I reevaluate. Is that gotten better? Have other outcomes gotten better over time? John, what about you?
Well, unfortunately, my experience has been, and I think the feeling is that, yes, you're right. I would give a 4 to 6 month trial, absolutely, up to 6 months to see if a particular biologic is really helping a patient. But the onset of some of these drugs are very quick, but the offset can also be quick. So I usually tell patients if they do well after 6 months and they're not having any adverse effects and they're getting the benefits that you want, you really have to discuss that this is almost always going to be, with few exceptions, a long-term therapy that is going to be needed until maybe the next best thing is available, until we have something that is going to be more permanent. So none of these are permanent, and so that is the issue I think that we're wrestling with, is how to. Now, if you have a specific goal in mind, you have to realize that if you reach that goal and you stop the biologic, you're going to have to do something else to maintain yourself after that. If you could shut the inflammation off permanently, then that would be fine. But as I tell patients, inflammation doesn't take a holiday. Some drugs have a faster offset than others, and it depends on whether they're having more effect. So what I've noticed with dupilumab is a faster onset than the others, for the most part, because it's a receptor blocker. But at the same time, it seems to have a faster offset. And so whereas the other drugs may take a little longer to work, but the offset is a little longer. They do eventually offset. But for example, because there are secondary effects when you block IgE, you will have downstream reduction of inflammatory mediators. It takes a while after you stop IgE for the IgE to retool. And so it may take a few months before. And so the nice thing about anti-IgE and the anti-IL-5 medications is that if they're stopped, and what I'm seeing more and more of is now that we have patients on them for a few years, is that when they change their insurance company or they lose coverage or they change jobs, sometimes what happens is when there's a loss of authorization, there could be a 1 or 2 month lag in them getting their medications. And so for some biologics to have quick offsets, that can actually be sometimes really disastrous. Whereas with the ones that have a slower offset, it gives you a little more time and a little more leeway. And so I think our ultimate goal is to have some of these drugs become more longer lasting. And I think that's the hope for future sort of takes on this. Of course, they're great advancements as they are compared to what we had. And I'm a lot older than you, Mike, and I remember when we had very little to treat asthma with. And so the fact that we even have these agents is really a big advance for the refractory patient. But I'm hoping that we go beyond this as the years go on.
Yeah, I think your message that there are no disease-modifying therapies for chronic rhinosinusitis, nor for asthma, frankly. We have to continue to give these therapies, and if we stop them, then patients may do poorly in the short term. We have another question here. For combined rhinosinusitis, nasal polyps, and allergic asthma, what's the best biologic? This is a great question. In fact, there was a recent article comparing outcomes. I think it's very hard to compare apples to oranges in different study designs, in different patient populations, looking at different outcomes. They all provided excellent results across the board. I think what you want to do for patients you really want to identify what type of asthma they have and what type of chronic rhinosinusitis they have. What's the endotype? And you want to look at biomarkers. For the asthma component, I generally look at exhaled nitric oxide, which is IL-13 mediated. I look at IgE levels and propensity for allergies, and I take a good history. And I look at blood and tissue eosinophil counts. And I generally look at the dominant biomarker. So if someone has, an eosinophil count above 1,000, I'll generally go with an anti-IL-5 therapy. If the exhaled nitric oxide is one of the higher biomarkers, above 100 or 200 or so, I'll most likely go with dupilumab. If the allergies are a key part of the history and their eosinophils and their nitric oxide levels aren't that high, then I'm more likely to go with omalizumab. John, what's your approach?
I agree totally. I think you need to do as much as you can to endotype based on the markers that we do have, which you did mention, and try to get a gestalt based on your history. I mean, early onset atopic disease is going to be quite different from, adult or middle age onset eosinophilic disease. And I think that, the biomarkers of nitric oxide and IgE levels and tissue eosinophilia is just as important as peripheral eosinophilia. And so thinking of those, and of course, does the patient have other comorbidities would be the way you would decide. And I pretty much agree with everything you said.
The other point, you said it would be great if we had longer lasting therapies. There are therapies in development. There's a long-acting anti-IL-5 therapy called depemokimab, which is going to be hopefully administered every 6 months. If it gets approved for asthma and chronic rhinosinusitis with nasal polyps. I think we're nearing the end of the hour. I think we've got time for one more question, then we'll wrap things up. Let's see. Here's a great question. If costs weren't a factor, would the biologic be considered first line instead of surgery?
Say, what's the question?
If cost weren't a factor, would biologics be considered first line instead of surgery?
So again, this is something that I think is a shared decision-making process with the patient. And, you're going to have to just consider all the facets of treatment, long-term treatment, and cost is a big barrier. If cost was not a problem, I definitely think that they would be moved up in the algorithm. There's no question that that's one of the reasons. And the other thing that we really don't have, Michael, is very long-term studies. We may have 4 or 5 years worth of data, but we really don't have, 20-year or 10-year data yet. And I think that it took us a lot of years before we realized that proton pump inhibitors were not really great for long-term use. It took about 20 years before that data came out. So keep in mind the fact that we don't have long-term data. but cost is definitely one of the impediments. And so, and then the question is, how quickly does the patient want to feel better? A lot of patients, you have to understand, you have to put surgery in perspective. It's not a cure. It's just a start. It's a way to reset things. So I think we're getting really close to the end. But I think it was a very, very great discussion, Michael. I really learned a lot from your presentation, and I think the questions were good, and I would like to thank everyone.
Yeah, thank you, John, and thank you all for participating. Great questions. There's going to be an online component to this program as well, and you can get a CME certificate if you attend the webinar completely, and after which you will be able to participate in a brief evaluation and download your certificate using the link emailed at the conclusion of the program. Again, you have to complete this evaluation by September 24th of this year. So thank you so much. This has been a wonderful program. I've learned a lot. John, thank you so much for educating me. Great presentation. Thanks, great discussion, and look forward to more programs and more advances in the management of chronic rhinosinusitis with nasal polyps. I'm really excited that we have all of these therapeutic options, and hopefully we'll also come to a time when we may be able to offer therapies that can prevent the nasal polyps from forming as well. And that's one of the other questions that came up. It looks like it just came up as well. So thank you so much for all of your attention this evening. It's been a great program, and good luck. Thank you for everyone's attention.